All right. Who would like to discuss? Who would like to present a case? Who would like to discuss? Who would like to present a case? Oh no, I have echolalia. Please make it stop. Which I'm not sure that's echolalia. I think that's repeating what other people say. I'm just repeating myself. Auto-echolalia. Anyone like to be a discussant with Mattia? Ideally someone identifying as a woman, and would love to have someone present a case. Maria has a case, phenomenal. All right, we are 2 out of 3, 66.66666666% of the way to getting started. Anyone like to discuss with Maria? It's going to be an amazing case, I'm sure. And Mattia is excited to discuss. Someone to join Mattia, please. I'll look through the chat. Anyone? All right, Mattia and Maria, why don't you introduce yourselves, and hopefully that will inspire, this icebreaker will inspire someone to join you.
Certainly. I'm Mattia, I'm a PGY1, almost done with my intern year. I'm categorical in neurology in Charleston, South Carolina. Only recently found out about the clinical problem solvers, thanks to actually our internal medicine morning report has used the templates from clinical problem solvers. So I've really enjoyed the podcast, and this is the first time that actually my schedule works to join a virtual morning report. So very happy to be joining.
Fantastic. So excited to have you. Congratulations on being days away from finishing the most difficult year in the entire process, and excited to hear you will soon be home in neurology. Fantastic. I'm sure many are feeling inspired to be your co-discussant, knowing they have a future neurologist on the team, although no one has stepped forward yet. Maria, do you want to introduce yourself, and we'll see if this dynamic duo inspires a third to join.
Hi, yeah, I think somebody actually volunteered, but I have to check. And I'm Maria. I have a case. I'm really nervous about it because it's a case I saw back in 2018, 2017. And I am not organized as Robbie and Reza, so I don't have anything written down. So I had to go by memory, but it was such a memorable case, and I want to share it with all of you. So very excited.
Great, excited for your case, Maria. So last call, anyone like to join Mattia and Maria and myself? So Mathieu said he'd be happy to do it if no one else does. Going once? Anyone? Going twice? All right. Mathieu, you're up. Feel free to introduce yourself, please, and we'll go ahead and get started.
Hello, everyone. I'm Mathieu. I'm an emergency physician and trauma team leader in Montreal, Canada.
Great. And I remember you had a brilliant discussion before and showed us spontaneously that the pronunciation is Guillain-Barré syndrome and not Guillain-Barré syndrome, which I had been mispronouncing for the better part of 2 decades. Maybe not 2, 1.5 decades. Okay, great. Fantastic. So Maria, would you like to present just the chief concern, just the chief complaint, and Mathieu and myself will begin discussing.
Perfect. So the chief concern is going to be increased drowsiness.
Increased drowsiness. Okay. Mathieu, you're about to be a neurologist in training here. You hear increased drowsiness on the pager. You think just 2 words. What am I supposed to do with this? But as you get your hammer and things into your white coat pocket and go to do one of your first consults, what's running through your mind here with this chief concern?
Yeah, I think it's a fascinating and kind of vague chief concern. So, well, you know, in neurology, we always think about the timing and the localization, and we kind of have neither here. Now, I'm thinking that the timing will be everything here, but just to start, I think that in terms of localization, we should not forget that drowsiness can be caused by pretty much anything. in terms of systemic things. You know, it can be something hematological, it can be something related to the cardiovascular system, it can be something related to the lungs, you know, if they have COPD, if they're hypercarbic, hypoxic, and so forth. So I think it's important not to forget those things. Now, in terms of localization, we did the neuraxis. Of course, drowsiness, we know that it localizes mostly to the cerebrum, although if we're thinking of drowsiness as impairment of awareness or consciousness, then it would localize either to the whole cerebrum, to both hemispheres, or to the thalami, or to the RAS, right? The pulse, essentially. So that's a thought. Now, what can impair both hemispheres? Either they're having a massive stroke that affects everything, a basilar infarction, something like that, or we could think, if it's more of a subacute problem, we could think of something toxic metabolic, and we go back to our hypoxia and hypercarbia and drugs and so on and so forth. You know, there's a little bit of research talking about the cerebellum and awareness, but that's kind of niche. So that's where I would localize it mostly, and go from there. And then let's think about time course. If it's of course a hyperacute process, then a seizure comes into mind, right? A syncope comes into mind. So those are my thoughts. If it's more, if it's a longer process, if we're going all the way to subacute and chronic, then we can start thinking about degenerative causes. Of course, dementia can make people more drowsy, but I really think that I will be very interested in the vitals here, in the time course, and then we can start thinking about the mental status exam and go more into really fascinating discussions about exactly what is the cause. You know, that's where I would start.
Great, fantastic discussion. So I agree, right? If this is drowsiness, what's meant here? Is this an impairment of level of consciousness, or is this sleepiness? So are we dealing with a sleep disorder, right? And those sleep disorders can include lots of things. I won't get into too much detail, so we give Matthew some space to discuss as well. But I agree with you. Is this a sleepiness, or is this an impaired level of arousal? And so you took the impaired level of arousal route, and it's a neurology morning report. If Maria is just giving us sleep apnea, that is something that can fake us out for dementia, can cause a headache disorder, can cause cognitive concerns. Like I said, people can be concerned for dementia, can cause decreased attention, memory, during the day, because patients are so tired, as we all know or will know in medical training from how your mind feels with chronic sleep deprivation, right? Or is this an impairment of awareness? And you said then we'd want to think about the localization. So starting from the bottom of this reticular activating system, we have the upper pons, or sort of lower midbrain, that projects to the bilateral thalami, which project to the bilateral hemisphere. So do we have a bihemispheric process here, a bithalamic process here? Do we have a brainstem process here? Or, as you said, do we go outside neurology and say this patient has anemia, or this patient has an electrolyte disturbance, or this patient has something wrong with their respiratory pathway, such that they're hypercarbic or hypoxic, and all of those could make them tired, or if very severe, could affect their level of consciousness. So those are all things that I think are on the table. And then, as you said, once we have a better sense, this starts to sound very neurological and localizable, right? Then we want to know the time course. Are we thinking about someone who's just suddenly become increasingly drowsy? You mentioned, could they have had an unwitnessed seizure and now they're postictal? Could they have had a basilar thrombosis and have become acutely comatose or near comatose from that, and other possibilities? Great start. Mathieu, if a patient came to the emergency room, we'd presume this was a hyperacute, right, sudden problem. So I won't confine you to that. But what's running through your mind when you hear this chief concern? And feel free to take the emergency room approach, presuming this could have been hyperacute or not, as whatever you'd like to discuss.
So hearing that chief complaint in the ED, I would probably deploy my approach to altered level of consciousness, which means that before starting to think about the lung differential, there's a couple of steps I would go through, in the sense that I would go through ABC first, make sure his airway is patent, is breathing, oxygenating, ventilating, perfusing. And then I would look for the two reversible thing that you won't want to miss. I would get a glucose, look for a opioid toxidrome. These are the two things that you can reverse in a couple of seconds. Then I would go through a coma exam, basically actively looking for signs to try to figure out if that is structural versus non-structural cause of altered level of consciousness. Then at this point, most of the cases, there will be a hint about what is going on. If not, then I would go through the list of meds, order some labs, order a CT, and then go from there. And usually at that point, if there's no obvious cause, then I have my altered level of consciousness checklist that I would go through, which are the thing that is being mentioned in the chat.
Yeah, great, fantastic, Mathieu. And I think it's great hearing Mattia and Mathieu from their different vantage points, right? So much of this would depend on the context in which the patient is presenting. And Mattia just finishing an intern year, top on his hypercarbia, right? If he's getting called in the middle of the night for a patient on an internal medicine ward who has become sleepier. Maybe it's just because they were asleep and are woken up. We've been paged for that at night, right? But I'm thinking of acute medical medical sort of illnesses. And Mathieu thinking if someone is coming in with this situation urgently, right? The context is the emergency room and this is acute, looking very quickly for things that are life-threatening but quickly reversible. Hypoglycemia, hyperglycemia as well, toxic ingestions, other metabolic disturbances, right? And if nothing is coming back on a first pass and the exam doesn't show that the patient has a particular odor of alcohol or some sort of stigmata of carbon monoxide poisoning or other obvious localizing features on a coma exam, the eyes are pointed one way or the patient is twitching or something like this, that we're probably going to need some neuroimaging. And if we still don't know the cause, right, then we're sort of not totally relaxed, right? But at least we know that sort of very sudden emergent things are probably off the table. And then we're dealing with the emergent, but not instantly reversible things, right? Things like meningitis, encephalitis as well. I think this has been a fantastic discussion. And I always like to draw out as far as we can with the chief concern, just to see what comes to mind, right? And what we can do with it. And the further we can sort of draw this out and the more we can kind of think of what our buckets are and what would push us in one direction or another, then we're really going to the HPI with certain hypotheses that, you know, as soon as we hear that time course, as Matthias and Mathieu said, as I said, as soon as we hear that this has been going on for seconds, minutes, hours, weeks, months, days, years, right? Suddenly our mind is going to shift in a different direction. And as soon as we hear more about the age of the patient, the past medical history, et cetera. And of course, the exam will be very telling. So I think, yeah, the way I'm thinking about this, as I said, and as you both have said, is this a sleep disorder? Does this patient have narcolepsy, right? And they have, they're falling asleep spontaneously. I'm not sure they usually describe themselves as drowsy, just that they fall asleep a lot during the day. Does this patient have a sleep disorder like sleep apnea, some other sleep disorder like insomnia that's just preventing them from getting a good night's sleep, and so they're tired? Or is this altered level of consciousness? And then we're thinking about our usual things we would think about for altered mental status or coma. And to me, I divide those essentially into medical and neurological, right? Many of the medical causes that have been listed, toxic, metabolic, excuse me, medication and drug. And on the neurological side, then we're in our usual time course sort of buckets. And I divide those, as people know, into four. I divide acute into hyperacute, meaning truly sudden, seconds, minutes, acute, meaning kind of fast, but not sudden, hours, days, chronic on the final extreme being years, and then subacute, something between that, weeks, months. So whatever this is, right, if it's aphasia or if it's weakness or if it's sensory loss or visual loss, if it was sudden, our list is pretty short, right? This could be a vascular problem. This could be ischemic stroke. This could be intracerebral hemorrhage. This could be subarachnoid hemorrhage. So a vascular possibility. Mattia mentioned, could this be epileptic in some way? Are these actually episodes of altered consciousness where the patient is postictal afterwards? People aren't sort of recognizing the seizure part. That's possible. Trauma. Other sudden things that can happen in neurology, migraine, although a migraine can make people feel tired, right? But probably not described in this way without headache being part of the chief concern. And then always toxic metabolic drug medication, always on the list. If this has happened,
Is it my turn? I'm sorry.
Oh, sorry. Somebody booted me off. I think someone else must have logged in. Phone. Nope, sorry about that. So I'm not sure how much I got lost, but I did my hyperacute, acute. So we'd be thinking about infections and inflammatory conditions, right? So is this meningitis, encephalitis? We know this is a brain problem, not a spine problem, right? Is this an inflammatory demyelinating condition like acute disseminated encephalomyelitis? An acute demyelinating syndrome. To get an MS flare, that's just sort of, those are usually more focal, but you can get a fulminant demyelinating syndrome like ADEM or other fulminant demyelinating syndromes. And then subacute, we could think of some longer term infections or more chronic infections, fungal, tubercular, neurologic complications of HIV, AIDS, and inflammatory conditions as well. Could this be an autoimmune, paraneoplastic, antibody-mediated limbic encephalitis? Again, drowsiness is the chief or only or main concern, would be a little atypical, but just filling in our buckets here. And then neoplasia, right? If this patient has a tumor growing in a particular spot that's causing progressive compression on the frontal lobes or the thalami, the brainstem, is the patient having a tumor that's not pressing on any of those structures, but causing progressive hydrocephalus, causing a decreased level of arousal for that reason. And then chronically, we'd be thinking about degenerative causes, right? Again, increased drowsiness is the chief or only concern of a degenerative condition, might be a little hard to make sense of, but that could be the patient's way of describing some decreased attention or level of cognition. We'd be thinking about maybe a dementing syndrome. So that sort of lays out our landscape, right? And so we'll be very interested to hear, Maria, what's going on in the HPI here to help us figure out our time course, where the patient is presenting, and any other features that might guide us here.
This was an amazing discussion, but I won't say anything because I have like the worst poker face. So this was a 13-year-old girl who was transferred from a neighboring hospital due to unresponsiveness. The mom says the day before, her daughter had come home from school complaining about like a headache, blurry vision, and she felt really sleepy. She gave her some Tylenol, and then the girl took a nap. She woke up a couple hours later, and the mom remembers she had tripped over some things on the floor and was babbling, like she couldn't understand what she was saying. She thought she looked very strange, like she was drunk or still asleep. The girl told her mom she didn't feel okay and complained about blurry vision, and then went back to bed. The girl slept through the entire day, and the next morning when she had to go to school, the mom had a hard time waking her up. She had to like shake her for her to open her eyes, and when she woke up, she seemed very confused, had slurred speech, and so she decided to take her to the hospital. In the neighboring hospital, they administered naloxone. She didn't respond, and she was transferred to our hospital. In past medical history, the mom said she was like a healthy girl, no previous illnesses. The mom says the girl had the flu last week. Family history, the dad recently passed away from a gunshot wound. And social history, the mom was very concerned because they had recently moved to another school. And then there was like the kids around the new neighborhood consumed more drugs than before. So that's the aliquot.
Wow, there is a lot there. I think we were all surprised to hear the age of the patient, right? And judging from people's eyebrows, or maybe you didn't notice from my eyebrows reacting to that. Great. I think Mattia discussed first last time. So Mathieu, what do you thinking now this does look like someone who might be brought to your emergency room based on the time course here and what's running through your mind.
Yeah, so that is confirmed to be altered level of consciousness. So we would approach it the way we've discussed it earlier. I think the history of a headache that preceded the altered level of consciousness is useful in narrowing a bit the differential diagnosis. So I would still, in real life, I would do a broad workup. I would still be thinking about like different possibility, including intoxication, but I would probably be going through my headache schema and superposing it to the altered level of consciousness schema. So that could include anything like intracranial bleeds, some cervical artery dissection, some cerebral venous thrombosis, any hypertensive headache disorder that would be complicated with the altered level of consciousness. Was there a previous mass that led or something like that? And then with the idea of the notion of the recent viral infection, is that some meningoencephalitis or some acute demyelinating process? The other thing in terms of intoxication that could give a headache followed in the next few hours by altered level of consciousness is carbon monoxide intoxication that you mentioned earlier. So that would be something not to miss, and that would be easily ruled out by a blood test. So these would be all the things that would go through my mind. I would complete my coma exam as we discussed earlier. And the truth is that she would probably be in the CT scanner in less than 10 minutes in real life. And then we would see from there. I think that the first, we would do a non-contrasted CT, which I believe might not show us the answer here. And then, but from there, we would see what would be the next probably vascular imaging.
Great thoughts here, Mathieu. Right, so this is acute altered mental status, right? Maria wanted us to have a very broad discussion by saying increased drowsiness, and that is probably, it sounds like what the mother brought this young girl for, right? But we have we're now seeing that there is some sort of prodrome, as you said, immediately of headache, blurry vision, that's sort of progressing to an altered level of consciousness, and that had a prodrome of some flu-like illness. So we have to be worried about sort of the acute bucket here. This doesn't sound like it was instant to make us think per se of a ischemic stroke or some type of hemorrhage. You might say, well, this is a 13-year-old girl. Yes, children can have strokes actually from in utero to the last day of life. It's possible to have strokes. Obviously, the risk factors and reasons are different stages of life. But this is a little bit, it's fast, but it's not instant, right? So I think the only vascular etiology that you pointed out, Mathieu, very astutely, that could present in this way is a venous sinus thrombosis, right? That the patient is developing headache, blurred vision, symptoms, signs of elevated intracranial pressure. And then this is sort of crescendoing into an altered level of consciousness. That could certainly be the picture of a venous sinus thrombosis amongst some other things too. So I think of our vascular causes, that's sort of an exception that doesn't usually present suddenly unless it leads to hemorrhage or ischemia, but usually there's a few days at least of headache, visual changes, etc. I think probably we're then moving, as you said, into the acute bucket. Is there an infection? Is there an inflammatory syndrome here? And how is that related to the flu? So I think those are great thoughts. And I agree with you, in emergency rooms with a CAT scanner, probably the patient would be passing through it like a metal detector right on their way in to get pictures of the head, so we are oriented in one direction or another. But we'll do this the old-fashioned way and try to tease as much as we can from the history and do an exam, although in real life, as we know, often neurologists are called, and they're being called because of the imaging. And we say, well, tell me what the patient looks like. And I say, oh, they have this on their scan. Well, what do they look like, right? Because the scan and the patient don't always totally correlate. Great. Let's see how we are at time. So I think I'll come back to you for the exam, Natia. So a couple of thoughts here. I think, so when we say the age, and now we have this syndrome, so let's actually take the age out for a moment. So we have headache, blurred vision, and altered level of consciousness. To me, that package is really making me think of elevated intracranial pressure. right? Headache obviously has a broad differential. We've talked many times about primary and secondary cause of headache. We won't go down that road today. Blurred vision, right? We've talked about, is it double or is it blurred or is it a visual field deficit? We won't go down that road today because the main thing here is the altered level of consciousness. So probably not bilateral optic neuritis or something like that, although could be. So when we have that package of elevated intracranial pressure, the intracranial pressure is accounted for by essentially 3 elements in the skull: the brain, the CSF in the ventricular compartment, and the blood, mostly in the venous system. And more or less, the brain is about 80%, and then the CSF and blood each account for about 10% each. So as we know, if you eat a large meal, right, the abdomen has plenty of room to distend, right? If you take a big breath, even though you have a rib cage there, you can expand your lungs. But the skull took protection over flexibility, right? Because it needs to protect our most important non-transplantable organ upstairs. And we do that with a very thick, hard skull, which is good if there's a knock on there from an injury or trauma, but not so good when there's pressure building up inside, because there's not much place for the brain to move and you risk a herniation syndrome, of which there are various types. So if there's a little bit of a rise of intracranial pressure due to a brain process or a CSF process, the other compartments can accommodate a little. We can squeeze some blood out of the venous system. If the problem is in the brain, we can sort of collapse the ventricles a little bit, but that pressure volume curve, it gets pretty steep. And once you are off to the races there on the steep part of that curve, then you can start getting into trouble pretty quickly. So the blurred vision could be because of bilateral or unilateral 6th nerve palsies. The 6th nerve goes over the clivus, has this sort of tortuous intracranial course, and that's called a false localizing sign if we were to see 6th nerve palsy on her exam. False localizing because it looks very focal, right? But it's actually from a general process of elevated intracranial pressure. Or it could be pressure on the optic nerves themselves. So we'd want to see if there is papilledema. And the optic nerve is obviously not a place of sight, right? That's just where all the neurons are going back, but it's very close to the macula. So you could get some central vision loss if there's swelling of the optic nerve. So then what can cause elevated intracranial pressure? Well, anything in the brain, anything in the CSF space, or anything that's increasing the blood volume. Usually that's going to be venous sinus thrombosis, problems with venous outflow. It would be very uncommon to get hyperemia so much that you would have arterial side volume increase to increase the intracranial pressure, though can occur. But most commonly, these are going to be things in the brain, and it can be anything that takes up space in the brain, whether that's a hemorrhage or a tumor, a fulminant demyelinating syndrome, an infectious problem, meningitis, encephalitis, all that inflammation, right? And then problems with the CSF compartment, which would be hydrocephalus, which could be communicating hydrocephalus, meaning all the ventricles can communicate, but there's some problem with the meninges such that you're not reabsorbing CSF through the arachnoid granulations back into the venous system, or non-communicating, meaning there's some blockage in the ventricle or in the ventricular system itself, a tumor or a large mass lesion in one hemisphere blocking off one aspect of the ventricular system so the ventricles can't communicate with one another. So those are possibilities. Now let's take the context here. This is a 13-year-old girl with a recent infection. So was that the flu, or were those flu-like symptoms in a patient who was developing meningitis or encephalitis? Is this a post-infectious phenomenon? And then in this young age group, I would think about ADEM, which I mentioned earlier, acute disseminated encephalomyelitis, which is a condition which what it sounds like, it's acute, it's disseminated encephalomyelitis. And the encephalo is the brain and the myelitis is the cord, though you don't always have both. I think of it like the CNS cousin to Guillain-Barré syndrome. It's hard to make that change, Mathieu, even though it was so nice to hear you pronounce it in the native French, because Guillain, see, I had the gears to redo my neural circuitry on that, because Guillain-Barré, right, is a syndrome of the peripheral nervous system that is acute. It's often demyelinating, though can be axonal, and ADEM is an acute central nervous system demyelinating condition. And it can be post-infectious, rarely post-vaccine, and it tends to be in younger people. It can be the first presentation of multiple sclerosis. And we've learned recently that many patients with this condition have a newly described antibody called MOG, myelin oligodendrocyte. What is MOG? I am reading about it recently because it's new, and I'm actually blanking on what the O and the G stand for. Someone can help me out in the chat. I think myelin oligo is the O and the G both part of that oligodendrocyte.
Glycoprotein, I think.
Glycoprotein, thank you. It's always the first year of medical stuff that I just blank it out. It had glycoprotein, and I glazed over. My G is for glaze, yeah. So this is anti-MOG, and this has sort of been a carve out of NMO, which was a carve out of MS, right? People realize some people with MS look like this. They have a lot of optic neuritis, a lot of myelitis that's very longitudinally extensive, and people found an antibody. We still don't have an antibody for MS. Who knows what's going on there? But now we have this NMO spectrum disorder, right? And then people said some of those patients look like they have NMO, but they don't have the antibody, and they have this antibody to MOG. And some of those patients clinically have ADEM, some have optic neuritis, transverse myelitis that tends to be like NMO, longitudinally extensive, but unique, that it often goes down all the way into the conus and tends to affect the gray matter of the core. They have this H sign I was just reading about in an issue of Continuum, that the gray matter is sort of hyper intense. And I think that patients with, actually, I'm not sure actually. I think some of those patients will have a monophasic course and some will relapse. And I think that correlates with whether the titer goes down of the MOG antibody after the patient has this episode of ADEM. But if you told me it's a young girl with a sort of a very diffuse syndrome with altered mental status and headache after an infection, I think the first thing that would jump to my mind to anchor on it would be ADEM. I just think the other thing we want to think about is the report of new drugs being consumed in the neighborhood. And this young girl just had her father suddenly pass away. Has she been involved in any of these drugs, and might we not know what they even are, and might they have more effect on a young person than an older person? Why the headache and blurry vision? That really makes me think of elevated intracranial pressure, but the rest, the altered mental status and the sort of clumsiness, could that be drug induced? And then I guess the last thing is flu plus Tylenol. What is it? Oh, it's infection and aspirin, right? Ray's syndrome. Which one is it? Someone in medicine can help me, right? Not Tylenol, it's aspirin. But could there be something else going on here where the patient takes Tylenol and is pushed into some type of liver failure? And we're back to Mattia's original idea that this is medical. And have we tipped the patient over that maybe had a subacute or liver condition, or the combination of Tylenol and some drugs in the neighborhood led to acute fulminant liver toxicity, which can cause altered mental status due to whatever liver was supposed to be metabolizing is now not metabolizing, and the brain is bathed in bad humors. Or I believe Ray's syndrome, which again is aspirin, I think, so it's not this. I believe the pathology in the brain is cerebral edema. So we'd have, so I think toxic metabolic always on the differential. We have a couple ways that could be spun here, but if you took out that lower left corner of the history and the social history, I think ADEM would be top of my list. So, okay, so it'd be interesting to hear the exam here. Mattia, since you're going to discuss the exam, when you're going to see this patient, what are the things you'd like to focus on here in the exam that's going to help us, might help us understand what's going on? If you could check, you'll do a full neuro exam, I know, because you're about to be a PGY2 neurology resident, but if there are a few things you're really looking for on that exam that are going to help us here, what are you looking for?
Yeah, I mean, if we're thinking about this possibly being a space-occupying lesion causing increase in intracranial pressure, I think papilledema would be a start. That's definitely something I'm looking for. I'm also curious to see what the pupils are doing. If the palms are affected, I'll see pinpoint pupils here, maybe confounded by possible opiate use too. Or if it's the midbrain, then we may see those like sort of midpoint pupils. But also, of course, I would look for a like blown pupil if we are to have a medical emergency. And then anything that would localize to one side, sort of either brisker reflexes on one side than the other. That's definitely something I'm interested about if we're thinking of this possibly being a mass on one side, pushing on the other side. I'd also be curious to see what, whether this person has any meningismus. I know that that's not the best way to check for meningeal inflammation now, but doesn't hurt to have a look there. And then, I mean, I just go through the rest, of course, cranial nerve 6 also, and generally just knowing what the level of consciousness of this person is. Am I going in doing a coma exam, or am I going in doing a neuro exam? Can they give me a history? Is this person arousable even? I don't think I really have a good idea of what situation I'm going to walk into. That being said, since we're also thinking about systemic causes, I mean, vitals will be key. I'd be curious to do a full medical exam, a general physical, you know, whether this person has any scleral icters, jaundice, you know, whether there are any crackles in the lungs, and so forth, without going, of course, without now having to list everything that's involved in a medical exam. But yeah, I think that's where I would start. And then knowing whether we have to go into like finer details of the mental status exam or not. That's where I would start, yeah.
Fantastic. Yeah, I agree with you. We will know already from the history, right? What is the level of consciousness of this patient? And some people use these terms, stupor versus coma, and these can be a little bit imprecise, where they give the GCS as 8, and I'm always wondering, well, what do they get points for? What do they lose points for? You get 3 just for being alive, right? So I always think it's much more helpful to say, as Mattia did, just what is this patient responding to? Their eyes are open or they're closed? If they're closed, do they respond to voice? Do they need loud voice? Do they need some gentle stimulation? Do they need sternal rub, right? So just to know what the level of arousal is. And then I forget which philosopher or poet said the eyes are the window to the soul, but for the neurologist, the eyes are the window to the localization, right? Just looking at the pupils, are they dilated or are they pinpoint? That could point in the direction of different toxidromes, right? As Matthias said, there's pinpoint pupils when you have a large pontine lesion. I think, though I've never really been able to confirm this, that's just because of the oculosympathetics, the pathway that is affected in Horner syndrome running through the pons, but it also runs through the midbrain and medulla. But I think that's why you get that. Or do you have lone pupils from intracranial pressure on the third nerves? Do you have an asymmetry in the pupils that would suggest a focal lesion with herniation? And then, as Matthias said as well, are we finding any focal or multifocal lesions on the exam, manifestations of lesions on exam? So asymmetric reflexes, or the patient may be moving one side of the body but not really moving the other, something that would tell us there's some focality here, or is this just sort of a generalized process? And yes, I admit we will need some information from the medical exam here, right? Is there jaundice? Is there anything else that would give us a clue? There's tachycardia or bradycardia, again, that could push us towards, on the one hand, intracranial pressure, right? Can have hypertension, bradycardia, or is there some pattern there suggestive of a toxidrome? So I think all those are going to be important. And then you mentioned the eyes as well, looking for papilledema. Papilledema does take some time to develop. So you can look in the back of the eyes and you might not see it, but there may still be elevated intracranial pressure. So I think those will all be helpful things to understand on the exam, the level of arousal, if there's any focality at all, what's going on with the eyes. And as you said, or are we doing a coma exam where this patient is not able to participate at all, and we're checking the eyes by oculocephalic reflexes and pupils and just sort of pinching the four limbs and seeing if they're able to react. Great. Fantastic, Mattia. Maria, what did you and your colleagues find in the exam?
Yeah, so I hope you like this physical exam. So the vital signs were normal. She seemed lethargic on initial evaluation. She could open her eyes spontaneously and to voice. She did not answer to questions. She seemed confused to time, place, and person. Her eyes, she could spontaneously open them, but she could not move in vertical or horizontal directions. She had a pupillary light reflex, but was sluggish, but it was there. Her pupils were isochoric and they were both normal size. She had no papilledema and no facial palsy, like the gag reflex was present. She wouldn't follow commands, but she moved all four extremities spontaneously. Reflexes in lower extremities were hyporeflexive, and we couldn't assess sensory or gait. That day, the level of consciousness seemed to oscillate between stuporous and lethargic, so she was placed under mechanical ventilation for airway protection.
Wow, okay. So Mattia, you told us what you were interested in looking for. Tell us how you interpret the exam, and then Mathieu will talk about what we might like to do next.
Maria, just one question. So you said horizontal and vertical impairment of extraocular eye movement. Did you test oculocephalics?
Ooh, I don't remember them, and so I don't have them.
Because I'm curious what other people have to say, because here, like horizontal and vertical impairment, if we're thinking of like a complete ophthalmoparesis, then I'm going to approach this very differently than just the patient not being able to just follow my commands. And that's where I would do oculocephalics in a patient. But so definitely something that was really interesting that you said, Maria, was the sort of waxing and waning nature of this within the same day. So I think that's interesting. I'm reassured that the pupils are still reactive and there's no anisocoria. So I like that. So it gives us a little bit more time. And I don't see anything that's localizing at this point, or that's lateralizing more so. I think, I mean, not oriented to time, place, and person is something that I was sort of expecting. The fact that it oscillates within the day is interesting. I haven't heard anything about any abnormal movements, but given all of this and the fact that we have an inflammatory process, I would be curious to see why this person oscillates, whether it's just the fact that they have an inflammatory process and that sort of waxes and waning, but I would be interested to place this person on EEG for the time being, at least. And then hyporeflexia, that may just indicate the fact that we have some generalized process to the brain that's impairing the nervous system, but also hyporeflexia is not particularly rare. Areflexia would be more concerning. So given all of this, I think I'm still going for this being an inflammatory process. I think ADEM or tumefactive multiple sclerosis would be topping the differential. I'm also curious whether this could be an infection, like an HSV encephalitis can present like this. And if we're going down the encephalitis route, then location will be key here, knowing where this person's from. Because viruses really vary according to region. Here in South Carolina, we have things that are very different than in Massachusetts and so forth. But arboviruses, West Nile, are always thoughts. Something else I was thinking about is whether this could, and this is less likely, but this could be more of a subacute process that's just becoming acute now, sort of a pseudoacute process. And that's why I would think about even possible tumors within children that are obstructing, that are giving rise to an obstructive hydrocephalus. I think it's less likely. I don't hear any reason why it would just suddenly become acute now, but that would be interesting. And finally, the waxing and waning nature of it, other than being, this person being in a, well, I mean, status would be unlike, non-convulsive status would be not the most, well, I don't know, maybe. but I'll stop babbling. I think just last thing, toxic metabolic causes are still in my differential.
Yeah, brilliant discussion. Yeah, so I agree. It does depend. Is there true ophthalmoplegia, right? Or is the patient just comatose and they can't move their eyes spontaneously? And we could check that by holding the eyes open and moving the head back and forth. And if the eyes do move in the opposite direction of the head, we know that 8 is communicating with 3, 4, and 6 through the MLF. And that tells us at least that the nerves, muscles, and brainstem are working. Although if there's an intoxication or the patient is sedated, they might be absent as well due to effects on the brainstem. So the context in which we would normally do them, right, if the patient is often going to be intubated, sedated, can be hard to interpret. But I agree that's important, because if you now told me headache, blurred vision, and complete ophthalmoplegia, meaning the patient cannot move the eyes, I'd be worried about the cavernous sinus here, and whether there's a cavernous sinus thrombosis, to bring us back to venous disease, as Mathieu had brought up earlier. But let's say that there's not ophthalmoplegia here, and this is not cavernous sinus thrombosis, then I think you're right that this is some type of brain process, and we're not really seeing focality if we take the eye movements as just part of the coma picture. The hyporeflexia, well, we know this is a central nervous system process, right? The patient is drowsy, but hyperreflexia, spasticity, all that takes time to come out. So very acute central nervous system insults like a stroke or spinal shock can present with hyporeflexia or areflexia, breaking the sort of lower motor neuron rules. Those upper motor neuron signs take time to come out. So I think, though we love the exam, I'm not sure it takes us too much further beyond our original differential, right, of a toxic metabolic possibility, something like ADEM, an acute inflammatory process, meningitis or encephalitis. As you said, looking for neck stiffness is pretty good for meningitis. It's Koenig and Brzezinski signs, which are only about 5% sensitive, because patients have to be really sick and pretty advanced, as they probably were by the time they got to Dr. Koenig and Dr. Brzezinski. And that time patients generally present earlier when at least they have access to healthcare. But encephalitis is on the table. And then your thought as well of, has there been a tumor, and the patients maybe said she had some headaches, but mom thought maybe she just didn't want to go to school, or she was upset because her father died, and kind of they weren't sort of part of the story. And then eventually intracranial pressure hits the tipping point. And in adults, tumors of the nervous system are most commonly metastases, and most commonly end up in supratentorial regions, though you can get metastases to the infratentorial regions. But in children, the most common tumors of the nervous system are primary tumors, and they do have a predilection for the posterior fossa, things like medulloblastoma, pilocytic astrocytoma, hemangioblastoma, lots of omas that can end up in the cerebellum or in the brainstem, and that could slowly cause fourth ventricular obstruction, leading to hydrocephalus. So I think that's a good point, Mathieu. This could be so-called pseudoacute, and there could be a tumor that was there as well. I think that's still on the differential. Great, so I think Mathieu is going to get his head CT, which he's wanted all along, and many of us have, right? And I think here the exam just tells us the seriousness and urgency, but maybe doesn't help us distinguish between these possibilities, although we're not seeing anything clearly for a toxidrome here, and looks more like a generalized picture of elevated intracranial pressure. So I think, yeah, ADEM, tumors, encephalitis, and toxic metabolic are all still on the differential. Now we're a few days out, right? So maybe toxic metabolic a little less likely, but not totally off the table. So what happened next, Maria? And obviously, if you're going to tell us something that's going to give the final diagnosis, give us a pause before, so everyone can wager their final diagnosis.
So yeah, this is like the second to last, like the next allocar is going to give you the diagnosis. So the drug panel and the BMP were normal. The initial head CT was normal. The MRI was normal. There was an LP which had like a normal opening pressure. I don't remember like the exact values, but basically 0 red blood cells, very few white blood cells, adequate glucose, a very high protein level, gram, cultures, viral panel, all of that was negative. The EEG showed diffuse slowing, but no seizure activity. We sent some antibodies. which took like the longest time to come back. And in the meantime, she was given pulses of methylprednisolone and IVIG. Almost 1 week later, she was weaned from mechanical ventilation. She had regained consciousness, was oriented in 3 spheres, but spoke with difficulty, had external ophthalmoplegia, had overall muscle weakness, and walked with a broad-based gait. Reflexes were still hyperreflexive. She had finger to nose and heel to knee that were ataxic, and she had dysdiadochosynesia as well.
My goodness, Maria. All right, Mathieu, you're up here. So we got a lot of data. I think we're all surprised at the imaging. We thought, okay, the head CT can be normal, you could miss stuff, but gee, a normal MRI takes a lot off the table here. So what's running through your mind at this point?
Yeah, I agree. The normal MRI is pretty surprising. I feel that in all the data we've received, the only abnormality is the increased protein in the LP. So I guess with the clinical picture, and we now know that she responded to pulse, steroids, and IVIG. So it's probably some kind of encephalitis now, which kind of, I suppose the antibody is going to give us the answer. I feel like most of the time there's still some abnormality on the MRI. So that is very surprising, especially with the residual neural deficit that she's having after she woke up and been extubated. I would have expected to have some abnormality on the MRI, but yeah, I would put my money on some kind of encephalitis that the antibody is going to specify.
Yeah, great thoughts. A couple of quick things. I forgot to comment on Mattia's comment, wondering whether this could be non-convulsive status epilepticus with this waxing waning mental status, which is a very important thing to have on your differential when a patient has unexplained coma or unexplained altered mental status or waxing and waning. Could this be seizure? And we didn't see any of that on the EEG, but that was important. And just one other thing that I thought of, which this is not because the imaging is normal, but since we always manage to talk about neurocysticercosis on this VMR, we usually think of the neurocysticercosis causing a seizure or causing a headache and then having either a circle with a dot or a couple of dots. There is a rare form that for some reason is more common in young girls called Cystosarcotic Encephalitis, where the patient basically has a miliary neurocysticercosis, just thousands, innumerable lesions, and they present with altered mental status. You would have seen that on CT or MRI, but just something for people to know about. I've seen one case in a 6-year-old girl who presented with seizures, aphasia, blindness. And the thing to know is that you don't give them antiparasitics or you'll cause fatal cerebral edema. You just treat with steroids and antiepileptics. And this girl got almost completely better. So anyway, just since we love talking about neurocysticercosis on this morning report, I thought I would tell you about that rare variant, even though I'm doing classic old school morning report where you talk about things that are completely irrelevant, but I couldn't resist. Okay, so I agree with you. The only signal here is an elevated protein in the CSF. And if this were an older adult, we'd say, and even that could just be spinal block from spinal stenosis. We wouldn't know what to do with it. But that does suggest something inflammatory. There's albuminocytologic dissociation. We all learn about that in the context of Guillain-Barré. I got it right the first time that time, but it took a lot of mental effort. Guillain-Barré, but that is non-specific for any immune-mediated process of the nervous system. So this is not ADEM, right? But it still has that time course. It has an elevated protein and it responded to steroids. So gee, it sure sounds inflammatory. Or did the steroids and IVIG, they just got poured into the patient who was spontaneously resolving from some post-infectious something. Kids can get ADEM, they can get post-infectious cerebellitis, where this is most common after VZV. These patients develop a very acute ataxia after a viral infection. The imaging can be normal, although you can see edema of the cerebellum. So, or if it's very symmetric, sometimes it might be missed by the radiologist, though I trust Maria's radiology colleagues. Did this patient just have post-infectious something? Post-infectious thing that kids get that affected the nervous system, and it was sort of looked a little bit like ADEM, and it had that tripping, and there's some ataxia now. Is it a post-infectious cerebellitis? That was bad enough that there was cerebral edema or cerebellar edema with some hydrocephalus. Gee, I would think someone would have seen that on the imaging. I'm not sure what antibody syndrome this would be. Maria is smiling, but I know you said no poker face, but you're not smiling in a particular direction to help us here. If you told me external ophthalmoplegia and progressive cerebellar dysfunction in a young person, not of this time course, there is a mitochondrial disorder called progressive external ophthalmoplegia, and then there's Kearns-Sayre syndrome, which I think has that as well. I never see these mitochondrial diseases, but I'm always waiting to see one, and so I've read about them that wouldn't have responded to steroids. So I don't know. This doesn't fit for me. This is not what antibody-mediated syndromes the kids get. Opsoclonus, myoclonus. No, it's not that. NMDA receptor encephalitis. I mean, this would be super fast and doesn't really have the kind of neuropsychiatric prodrome. So I think in real life, I would probably just call this some non-specific post-infectious thing. And I wonder if the antibodies will come back normal, but Maria always has a surprise for us at the end. So we'll see. So I guess I'm going to call this post-infectious, something in the family of ADEM, but obviously not having the imaging characteristics to meet criteria for ADEM. What are you thinking, Mattia? Mattia, just put your final nickel down here, and then we'll let Maria take us home.
Yeah, I'm definitely thinking, I mean, at this point, inflammatory. Something that they thought was super interesting is that this person has ophthalmoplegia, hyporeflexia, and ataxia.
Oh,
this
good.
triad in isolation makes me think of Miller-Fisher. Now, what, and they have albuminocytological dissociation. So I probably go with that. Of course, it doesn't explain the stem, right? So could this be a viral encephalitis that by the time they got to us was starting to resolve, and the viral panel was negative? I know there's so many viruses. We just had a similar patient. We had to get some in-house and some as send-outs, and they were all negative. But then even our ID experts told us to redo the LP because there can be false negatives and there is a hook effect, I think. So I think that would be my top in the differential, but there are so many autoimmune encephalitis, and I am more well-versed in the adult world than the pediatric world, so I'm sure there's even more antibodies there. But really, I go with this, and but open to learn about the new antibody, I'm sure. And in terms of antibody for Miller-Fisher, it's anti-GQ1B, I think.
So Mattia, this is the beauty of teams, because your insight that, hey, if it weren't for that altered mental status, we would call it Miller-Fisher syndrome, helped me think about something I hadn't thought about because I was so fixated on the altered mental status. But put us together and we have Bickerstaff Encephalitis, which is Miller-Fisher syndrome with altered mental status. And nobody understands how you can have Guillain-Barré, but are joking about pronouncing Dr. Guillin's name here will prove effective, because there is something called Bickerstaff Encephalitis. And there's actually some debate about this. One of my mentors, Alan Roper, who's written a beautiful book about Guillain-Barré that you can get. It's out of print, but you can get it for $2 on Amazon. It has reports of everything you could possibly see in every variant. And he actually believes this doesn't exist, and that patients with really severe Guillain-Barré and difficulty breathing just have delirium because they're in the ICU, and there's no evidence pathologically that their central nervous system is affected. But he debates in the literature, I think this other group from Japan, who I think they're from Japan, who has shown pathological evidence that this is Guillain-Barré, but it's breaking the rules and it's getting into the central nervous system. So power of teams, right? You saw the pattern here of Miller-Fisher, which had eluded me, that hyporeflexia I thought we can get rid of. And you said, no, we have to explain that. Hyporeflexia, ataxia, ophthalmoplegia, if that's your problem representation, that's Miller-Fisher syndrome, but the altered mental status doesn't fit. And so I think we would have to call this Bickerstaff encephalitis. And I believe it does still have the GQ1B. Sorry, we didn't let you opine, Matthew, but I just got so excited to say Bickerstaff. I've seen one, okay, we'll let Maria tell us now that it's TB or something, but I did see one very striking case of this, of a woman who had Guillain-Barré 30 years ago or something, had been taken care of by one of our attendings, was healthy, and came in with very rapidly progressive altered mental status, and was comatose and was intubated, and we didn't find anything on anything except albuminocytologic dissociation. She got IVIG, and one of our residents ran into her at Starbucks like a few months later. She was totally fine. And we were telling, Dr. Roper was one of the attendings I got to work with in Boston, this is Bickerstaff, and we got to hear this whole thing about how he doesn't believe it exists, and he's debated in the literature whether it's a real thing or just people with Guillain-Barré can be confused. Okay, I think you took us right up to the hoop, and you just put the ball there, and then allowed us to just tap it the rest of the way in. So the power of group thinking. All right, Maria, tell us that the patient had tuberculosis.
No, we debated this for the longest time because antibodies are super expensive. And just as we say, like, oh, why do we need neurologists? You can send like imaging out of everything. Like people also say, like, why do you need neurologists? You can send antibody panels of everything, but they're super expensive. So we did like the most extensive literature search trying to find like the antibody to order. Yeah, we were also thinking about NMDA, and it seemed very fast for us. And so we also did like ultrasound and like CT of abdomen, which was normal. So we were like, yeah, let's not go through that. And then as Matthias said, like problem representation was everything for us. So I remember stumbling an up-to-date like ophthalmoplegia, and then it always says like when you're considering ophthalmoplegia, consider MS, Miller-Fisher, and plus syndromes. And I was like, what's that and plus? And basically we sent the antibody for anti-GQ1B, and it came back positive. And that's also for Miller-Fisher, but the final diagnosis is Bickerstaff Encephalitis because of the altered mental status. So a syndrome inside a syndrome inside a syndrome, because it is part of the spectrum of Guillain-Barré, and it's also part of the spectrum of ADEM. So it's one of those diseases that we have to track because we're sure going to get more information about them, hopefully soon, because they're very interesting. And so, yeah, that's the final diagnosis.
Amazing case, Maria, from increased drowsiness to Bickerstaff encephalitis, well deployed so that we could have lots of far-ranging discussions along the way. I think interesting for all of us that we thought pretty early on, based on the time course and syndrome, that we were in the inflammatory category. Infections kept coming back, toxic metabolic kept coming back. And the key here, we said the exam wasn't that helpful, but actually that hyporeflexia, hard to know what to make of it when someone's in a coma. If it was very brisk, that might have been helpful. But once you, as we've talked about, when you have a complicated case, deciding what to put in your problem representation, what to leave out, can be very powerful. And Mattia put in a problem representation that essentially took us there and reminding us that Guillain-Barré can do many different things. And now you see it can even cause altered mental status, although debated whether that's primary or secondary. Phenomenal case, Maria, thank you. Phenomenal discussion, Mathieu and Mattia, and Valeria has been running out of space with teaching points. So feel free in our closing minutes here, Valeria, to pick a few favorites to highlight.
Oh, Willie, I'm sorry. I just wanted to point out, I forgot like how the hyperreflexia. Yeah, so you can get like Bickerstaff, and you can have like hyper and hyporeflexia. You can have like everything with the reflexes. And so when you have like hyperreflexia, it's considered like Bickerstaff plus GBS. And so, yeah, it's like, is it the same disease or is it different? I don't know. Just food for thought.
Yeah, if you look at this book by Alan Roper, like I said, you can get used on Amazon. It's an old book. It was, I think, just sort of they're reporting on however many hundreds of cases they'd seen in Boston over many years. You can, everything you think about Guillain-Barré, there's an exception. Well, you shouldn't really get sphincter involvement or pupil involvement, or you can get anything, right? So so great. Yeah, fantastic. Really wonderful case and discussion. Okay, Valeria, what are some of your favorite teaching points?
Yeah, so this was an amazing case. Thank you so much, Maria, and an amazing discussion. So we started with a really specific symptom, which was drowsiness. And so a really important question that Mattia pointed out early on was if this was an impairment of awareness, of arousal, if this was altered mental status, and also Aaron mentioned that it could be a sleep disorder such as narcolepsy. And I think the important equation in neurology that Aaron always mentions is location and time course to get the diagnosis. And I really liked that when Mattia, I believe, divided the location in systemic causes, such as metabolics or toxins, that were kind of in the top of our differential, and neurologic causes, such as something affecting the cerebral hemispheres bilaterally to cause this drowsiness, or in the reticular formation that could cause an impairment of arousal. And the time course, we also divided it in hyperacute, thinking about a syncope or seizures, acute, thinking about infectious encephalitis, or subacute chronic, such as degenerative disorders like dementia, and granulomatous infections that are never missing in Neuro VMR, and autoimmune etiologies was the case. And so in MIST, well, we have the mnemonic of MIST of altered mental status that we always know, but Aaron mentioned that his approach was medical versus neurological, not using the mnemonic, which was really great. And I really like that Matthew mentioned us how he will approach this case in the emergency room, prioritizing reversible and life-threatening causes, checking for the ABCs first, and then vitals, and then ruling out metabolic causes because it would be an easy exam, reversible treatment, and then looking for signs of localization, the Glasgow Coma Scale, and imaging. And then he also pointed out that this was like a pattern because the patient had a headache, visual changes, and the crescendo progression of the altered mental status that was kind of characteristic of venous sinus thrombosis. And Aaron also mentioned that this triad also made him think of elevated intracranial pressure. And that can be caused by the three components of the head, basically, changes in the blood, or the CSF, or the parenchyma itself. And a really important clue that gave us basically the final diagnosis was the fact that the patient had history of a recent infection. And so in the chat, they mentioned the possibility of ADEM or myasthenia. And ADEM is an acute demyelinating disorder, that's caused by anti-MOG antibodies and can be the initial presentation of MS. It's more common in pediatric populations, such as this case. And we also talked about the possibility of intoxication because of the medication the patient had. And Mattia also mentioned that looking for the pupils, it was going to be something that he was looking forward for the exam, differentiating pinpoint causes versus blown, and also looking for anisocoria in cases of medical emergencies such as herniation. And then something that I really, really like was the use of the Closephalic Reflex to differentiate true versus not true ophthalmoplegia. In the case the reflex was positive, was present, was absent, we will see a true ophthalmoplegia because that cranial nerves will be affected, versus if the patient was comatose, in that case we will see the reflex conserved. And so at the end, also Aaron mentioned the possibility of Cystosarcotic Encephalitis, which was something that I hadn't heard before, that is more common in young girls, that is caused by miliary lesions versus the normal kind of focal lesions by neurocysticercosis, and can be presented as acute, altered mental status versus seizures, which is the usual presentation. And finally, Mattia came with a triad of hyperreflexia, ataxia, and ophthalmoplegia, which made us suspect of Miller-Fisher syndrome. And that plus altered mental status was the final diagnosis, which was Bickerstaff Encephalitis. And so amazing case, and thank you very much.
Great, phenomenal teaching points, Valeria. Thank you so much again for putting this case together, Maria. It's very interesting and very well done. So we could discuss so many things along the way. And Mattia, brilliant discussion. I think we got to discuss your approaches to altered mental status. We even briefly talked about sleep disorders and examining patients in coma and thinking about sort of acute inflammatory conditions and all the different ways that Guillain-Barré can present, including this very rare Bickerstaff Encephalitis, which is Miller-Fisher syndrome plus altered mental status. Fantastic. All right. Well, thank you very much, everyone, and look forward to seeing you again next Tuesday. Enjoy the rest of your day / night / whatever time zone you're in. Thanks, everyone.
Yeah, thanks, Aaron. Thanks, Matthew.